So I don't know what time it is for you, but I imagine we're all at different time zones. So I will be talking to you about the French African Pediatric Oncology group that set up a hospital-based cancer registry in Africa. And firstly, I just want, why is this not going down? Okay, so just to give you some background about our group, it is a non-government organization that was created in 2000 by Professor Jean Lemaire, who is the head of the Pediatric Oncology Service in Gustave Roussy. And the vision of the association was really to treat African children in Africa with trained staff and to support the creation and the development. So this has been going on, as I say, for 25 years now. And on the right, you see some of the founder members that were there with Professor Lemaire with his red tie, because this was really his retirement job that he had decided to dedicate his time to. So for our this group, we had 5 pillars really that we've been building on, and training and education is one of the main areas for research assistants, for doctors, nurses, pharmacists, and also with a big area of leadership, because a lot of the time we're dealing with very young, newly trained oncologists or nursing staff, and really getting them to develop their services in areas that are not likely to have known much about pediatric oncology. Also, we have research programs, so multidisciplinary management for our research programs, and that has been developed from the year 2000. So there's some background in research before we started our registration. Also developing access to care, access to medication, oncology, treatment, etc., radiotherapy. There's also building local capacity and having home from home, so parents' homes. We also have twinning with oncology services in France and units, new units that have opened up. For example, the Institut Curie is twinned with Bamako. The Trousseau Hospital in Paris is twinned also with Guinea, and other units are twinned likewise. We also have a big component of advocacy in countries to develop advocacy on a national level, but also on an international level, so that this helps in the development of financing as well. So today, this group has 25 years of building a solid network in Africa, and you can see the different units that are right around Northwestern Africa, Central Africa, and right down to Madagascar. We have 24 pediatric oncology units today in 18 countries. And what I will be talking to you about is the hospital-based cancer registry, which is now opened up in 20 units. We have over 1,500 trained professionals, so doctors, nurses, pharmacists, again, more than 15,000 children that have been treated since the year 2000. We're very proud also of our African school, which is based in Rabat in North Africa. And that is a school that it was funded by the Sanofi My Child Matter program. And it is our president, Professor Laila Hissesen, who is responsible for that school. We also have therapeutic recommendations. Initially, we ran studies that were feasibility studies, and then later on, more in-depth studies having identified weak areas. These studies have been published. And again, we come to the advocacy, which is very important. And that is our site, if you want to have a look. So looking at the context of pediatric oncology in Africa, what is interesting to know is that registration began a long time ago, 75 years ago in South Africa, and a little bit later in Uganda, in Kiondo. Putting it on the international level, ARC started in 1966. And then when we look at the French Francophone Africa, it started a lot later. So in Mali was the first registration, population-based registration that started. And that was in Bamako, in the region of Bamako in Mali, and later followed by Ivory Coast in Abidjan. What's important also to know is that both of those cities, Bamako and Abidjan, have GFAOP supported pediatric cancer units running in them. And today we have 2 units in Abidjan. So registration does exist in this. It's quality of registration also is something that we work a lot with. And when we look at, this is the ARC GloboCan from the Cancer Today website, you see the registration and incidence are quite low in sub-Saharan Africa, where the incidence is very, very low, possibly because of lack of registration or poor registration. And this is the source of incidence data that is available for sub-Saharan Africa to produce GloboCan with national estimates in 2020. And here, the AFCAN, which is the African Cancer Registry Network, so the hubs, they have 20 countries that are covered by AFCAN, but as you can see, not all of the countries here that are the areas covered by the GFAOP, the registration is in countries, but not actually covering all the population or covering with quality data. And this is something, again, you see the countries, the 6 countries with high quality population-based cancer registries are the older countries. So we come back to South Africa, Uganda, and Harare in this area here. So the reasons for underdevelopment of pediatric population-based cancer registries are quite similar, I'm sure, to other developing countries and low-income countries, of poor diagnostic capacity, which I'll be showing you we actually identified very early on in our data, insufficient coordination of data sources, scarcity of adequate trained technical staff, absence of up-to-date population census, and also in Africa, a lot of on instability, political instability, with migrations of population, poor health infrastructures, and insufficient political will. But incidence does exist. We do have incidence. It was published, Eva Steliarova published in 2017, where age standardized rate was 56 cases per million for children less than 15 years, compared to here in France, where it's 161 cases per million for children less than 15 years. So there's quite a large difference. And we in the GFAOP hope that with increased diagnostic capacity, incidence should increase in these countries. So now I get to the part which is the French African Hospital Registry. The GFAOP, as you noted from the first few slides that I showed, never had the idea of becoming an epidemiological group, and our main purpose was treatment of children. However, given that we had access to information on children, we were collecting data from the year 2000, we did notice that we had a lot of difficulty in actually having follow-on information. We noted children that were registered for a study and then they disappeared. We didn't know anything about them. We didn't know what stage they were at. We didn't know what treatment they got, and we didn't know the outcome. And we had difficulty understanding why that was. But it continued happening in both nephroblastoma study, Burkitt's lymphoma, and we kept coming up with the same problem. So we decided that it was important to actually have data on all the children coming in, and not just the children for we had protocols. So we started off in 2016 with 10 countries, and you see here the different colors represent the 3-year grant funding from the My Child Matters program. Again, another 3 years, and this area here is from the Foundation S. In the beginning, we had 10 countries, 10 units that joined from 10 different countries, and this followed on right up into the most recent, which is in Congo, Brazzaville, and in Belgeville, which is the second unit in Ivory Coast. So the concept of actually having a centralized database where people locally would enter their data, and we used REDCap, which was something that was easy to use. It was light on internet, and so it was something that we thought was feasible, and it proved to be so. We also, at that time, in 2017, we started going to centers. The first center that was visited was in Abidjan, in Trécheville, which is the main hospital where the unit exists. And this was really an eye-opener for us, because we started seeing the reasons why collecting data was so difficult. One of the main issues that we came across that we were very surprised about was the lack of actual patient files and the follow-up on patient files. And when we started to inquire about this, what was happening was families would come in and they would buy a notebook, and in that notebook everything was noted by the oncologist on the treatment, on the history of the illness, etc., etc. But because the families had bought that notebook, they brought it home with them. So often they kept it, even with requests that it would stay in the hospital. And so finding information on children on a long-term basis was almost impossible. So those sorts of practices we had to discuss with hospital management to try to develop actual patient filing and have patient filing that was something that was going to be used as a long-term, having places for archives, etc. So they were sort of basic troubleshooting and finding solutions locally when we went on visits. And those visits continue today. We've run about 16, we've visited 16 different units. Each visit takes 1 week. Usually I would be accompanied by an oncologist or a research professional from France, a research professional in registration. So this is just looking at where all of the centers are. So you can see large numbers of, in red, are where all of the centers are, right down to Madagascar. Training is something that we have really been developing, and from the very beginning saw that this was very much a group challenge, and we had to bring the group with us. So we started, this was the first meeting we had in 2017 in Gustave Roussy. At that time we ran an in situ training, but we also started a 7-module e-learning, which was mandatory for all people who are entering data. So this would give us sort of a baseline of knowledge, and then we could build on that. And within that 7-module e-learning program, we have emphasis on cybersecurity, on the use of REDCap, and also on general information on childhood cancer. But we also target the 5 cancers covered by the GFAOP. In our in situ training, we have used this in situ training to make available information on how the different units can actually use their own data, so that they actually start owning their own data and get the idea, this is our data, this is what we can do with it. So we can use extraction data, manipulation of data, analysis, and at the end having a report that is usable for direction for maybe also ministries, and so that they see the use of the data and the importance of having good data. So also we saw during our development of our opening up of different centers that showed an interest in being involved in this project. Initially, yes, they would register, but then we saw sort of as time went on, we were getting less information, and that the energy and the time that had to be allocated to this work, they actually didn't realize there was so much time involved and necessity to go look for the data. So we ran a service that actually accompanies these young research workers, that they will actually have support, troubleshooting, and also it helps get to know the team. During the COVID period, which was a sort of a negative and yet a positive period for us, because it forced us to develop techniques to communicate and to develop other ways of training. The e-learning program was one thing, but we had what we called an open forum where we invited people to participate. And you can see here, this was during the COVID period, where we invited people to participate, firstly at a questionnaire, asking them what kind of training they thought was important. And they came up themselves with staging as something that they wanted to have more information about, abandonment and follow-up, because they were the areas that we were always sort of asking more about. And that led us to actually look at maybe doing and presenting work on using the Toronto staging, which is talking to you. The variables that we collect are usual variables on patient characteristics. We also collect a lot of data, a lot of information on dates, the start of symptoms, the arrival time, the start of the date of confirmation, the start of treatment, and also last news. For diagnosis, our confirmation, the information on confirmation is actually downloaded and added onto REDCap. We have disease extension and diagnosis information, again, information that is downloaded. We have information on what kind of protocol, and this helps us in our confirmation of diagnosis, where we look at the protocol that was used. Does that concur with the diagnosis? Does the location of the illness concur with the diagnosis, etc.? So it helps our quality. We do not collect information on all treatment. We just collect information on the date the treatment was started and what that was, if it was chemotherapy or surgery or surveillance. We look at the demographic information, the distances traveled, the residents, socioeconomic status, number of people in the family, and we also look at the education of parents, both mother and father. And this brings me to the development of, which was our first publication, and looking at the data from 2016 to 2018. At that time, we had 13 units that had participated. So children that are included are children that were 0 to 18 years. And what we noted was that a small proportion were in the 15 to 18 age group, probably because pediatric oncology in most of our units take children from birth up until 15 years. Outside of 15 years, they're referred to adult services. But in some of our units, because they know that there are protocols that would take children from 15 to 18, that's probably why the number is small, but there is a population in that age group. Also, this study showed us, we registered all children from the moment they arrived, and we were interested in looking at what was happening with children. So we saw large numbers of children that actually left the service, either abandoned or death. Again, they got some clinical diagnosis. So they had seen an oncologist. The oncologist had decided these are the sort of exams that need to be carried out to confirm. And again, a large number of children died before any confirmation could be established, or they abandoned the service. And this resulted in 28% of children who had some clinical diagnosis but never started the treatment. And later on, we were seeing 14% of abandonment during the treatment phase. So a large percentage, which is never noted. This group here is not noticed because abandonment is often during the treatment or once a diagnosis is actually confirmed. But we were identifying children that actually never got as far as a confirmed diagnosis. So ability to confirm the diagnosis, the range in sub-Saharan Africa was from 45% to 89% in some sub-Saharan units. And basically a lot of that was the responsible was because of lack of pathology services. Often new units were having to send their samples either to France or some to Germany, mostly in Europe. But when we looked at North Africa had 90% of cases that were confirmed. Also, we were interested in looking at metastatic disease. So 41% of solid tumors had metastatic disease. On what kind of cancers? Was also something that we identified, which was the large proportions of Burkitt's lymphoma. And this is again from 3,348 cases that were recorded during that study. And 20% Burkitt lymphoma, which is the highest proportion, goes into that category. Nephroblastoma represented 18%, retinoblastoma 14%, acute lymphoblastic leukemia 14%. What is interesting is that central nervous system tumors that represent about 29% of cases here in France is only 1.5% of cases in these hospital-based cancer registries, probably showing the weakness or the bias that is linked to hospital registration, where children are being referred when referring doctors know that there's protocol that exists. So we know that this is possibly one of the causes of the very low percentage of central nervous system tumors. We also noted a heterogeneity between units. So Burkitt lymphoma, as I say, was the high proportions, but not in all units. As high as 34% of all cases had Burkitt's lymphoma in Ouagadougou and in Abidjan. So about 60 cases per year, or 38 in Abidjan, were going into the units. If you look at it on a population base, the population in these countries is 22 million in Burkina Faso, where you have Ouagadougou, and 28 million in Abidjan. But the population less than 15 is very high at 40 to 43%, but still the numbers of cases are very high for Burkitt's lymphoma. When we looked at other units, especially Dakar, which is interesting because it really is sub-Saharan Africa, the proportion of Burkitt's lymphoma is very low, with only 5%, which is about the same as units in North Africa with 5%. When we looked at retinoblastoma, here again, I think it can be interpreted as the existence of specialized retinoblastoma services, certainly in Bamako, in the unit in Bamako, and also in Kinshasa. And retinoblastoma represented 27% of all cases in Kinshasa, 24% in Bamako, compared to Yaoundé in Cameroon, which is only 4%. So we had all of this information, which is very useful for what we were working on. This is a study. This was the study that was run looking at the staging using the Toronto guidelines. And here again, you see it was for 7 units. The cases were 2,446 cases from 7 units. And Burkitt lymphoma represented 22% of all cases. And right underneath, you see just 1.3 of central nervous system tumors. And when we look at retinoblastoma, represented 17% and 17% of renal tumors. So very high percentages again of these tumors. So why Burkitt's lymphoma? Why is there so much so many cases of Burkitt lymphoma in Africa? And this is something that this is the map that Burkitt himself produced in 1963, where we see that the black squares show the distribution of cases in his series that he identified. And you compare this with our table, our map showing the different units and the placement of each unit. So Burkitt's lymphoma cases are still continuing to exist in these areas with high numbers of Burkitt's lymphoma. So we also note the connection between Burkitt's lymphoma and malaria. And in sub-Saharan Africa, here the lowest is in the blue area. So it's the prevalence of the Plasmodium falciparum, which is responsible for malaria. And the blue area is the lowest area of prevalence, and red is the highest. And you see sub-Saharan Africa is where this Plasmodium falciparum is most prevalent. Also, 95% of malaria cases are coming from sub-Saharan Africa, and 96% of deaths from sub-Saharan Africa. And in that 96%, 80% are children less than 5 years. And that comes from the Malaria Atlas from malaria burden. So when we looked at this stage, we wanted to see if our data, using our data, if we would actually be able to stage according to the Toronto staging system. And we were able to stage 89% of cases for 11 cancer types. We were not able to stage acute lymphoblastic leukemia, nor were we able to stage the central nervous system or brain tumors. We were not able to use the ICD-0 classification because we did not have information on the morphology as precise as was necessary for ICD-0 coding. Then we wanted to look at outcome, and we were able to look at outcome for 1,686 cases for whom we had follow-up information. And this showed us overall survival. We were able to go really as far as 57, as far as 12 months, and that showed 57.8%. With confidence intervals at 55 and 60. And when we looked at the difference between units, we saw a huge difference between units. Some units had just 43% of overall survival at 12 months compared to 74% in other units. And this is overall survival. This has not been published, but it's of later data of 2019 to 2021 from 16 different units. And here we wanted to look at, because for these protocols, for these cancer types, protocols exist in the unit, and medication not always available, but it is more easily available. And the GFAOP has helped in providing medication for some of these cancers. And here we tried to look at to see if we could actually look at survival for this group, knowing that our data is better for this group. And we'll look at 63% overall survival at 30 months for nephroblastoma, 83% for Hodgkin's lymphoma, and 52 for retinoblastoma. But again, acute lymphoblastic leukemias and Burkitt's lymphoma is lower than the 60%. Well, we looked at overall survival, all cancer types, and we came up again with 57% at 12 months because of the severity of osteosarcomas and also hepatoblastomas, which bring down all of the results for at 12 months. Again, it shows the necessity to continue working on the data and to continue finding information at long term for these cases. So what are the key insights for data management? One thing that has really helped us was joining with the Child GIC or workshop, and especially Ava Steliarova, who has been very supportive of what we do, and also helping us have better quality and monitoring with regular reviews. It's something that we actually put in place, selection of variables to control and being more specific about, because we ended up having a large number of variables on our questionnaire, and most of the variables were demanded by the center because they want to have them for their own reflection. But from a GFAOP point of view, we'll probably never use all of that data. So we're selecting variables where we really want to use it in controlling and also for publications. Consistency in our checking of data and the site visits, which have been really, really very valuable. We still have a lot of work to do on our coding, certainly in the ICD-0 coding. The Toronto stage seems to be something that is working for us. And another area that we're still working on, this is one of the archive systems that exists So you can imagine trying to find any information on children in this type of an archive system is very, very difficult. So developing better archive system is something that we work on all the time with different units. Even file numbering and using REDCap, the REDCap number as a filing system is something that we encourage when no numbering of files actually exists. So the constraints and limitations. The limitations of diagnostic capacity is something that is very complicated, because we are dependent on pathology departments, and pathology departments are not always trained in pediatric oncology. So it's getting better training for pathologists, also getting better equipment. Again, we come back to the coding, which really is something that we're working on. The high dropout rate at an early stage also limits the data completeness, because we know that a lot of those children, you know, if they had stayed in, we would have had a confirmed diagnosis, but confirmation, they get excluded from our figures. Failure to manage the archives records, again, hampering long-term tracking and data quality. And strong dependence on external funding. So we're trying to develop knowledge locally so that governments will see that data is actually available and can be used. This is something that probably needs to be looked at on a long-term basis from the GFAOP point of view. The strengths. We have a very solid expertise in data collection and processing. Some of our data collecting group have been with us for 20 years. We have a very comprehensive training program, both online, in situ, and face-to-face. And this has really proven the effectiveness also on on-site monitoring. It helps in the communication with the groups. It helps in opening up the knowledge locally about the fact that registrations exist. Whenever I'm on site, I try to find, make a connection with population-based registries when they exist, explaining that the data is there. Of course, it's not our desire to push the unit to share the data, but we encourage them to share the data when population-based registries do exist. Strengthening data control by procedures that are put in place, and this is something that we're working on. Access to data, so getting people working on the data locally. We support when they have congresses. We will support and help so that they can use their own data, help them working on research projects, etc., so that everybody is actually gaining from good data and sees the necessity for good data. So also enabling the GFAOP to evaluate programs which exist, like giving evidence on different projects, and especially on early diagnosis. This is something that is very important for us. And in conclusion, in many of these countries, our data is the only information available on childhood cancer, especially on Burkitt's lymphoma. So evaluation of other projects like malaria control, etc., could be something that this data can be used for. So it's very important and crucial to maintain the quality of this hospital-based registry and enrich it with accurate and up-to-date information. But again, it remains a hospital-based registry with all of the biases that go with that kind of data. So direct access to clinical records and medical expertise can ensure better diagnosis capacity, but not necessarily, but also can ensure better staging and hopefully, with a lot of work, better survival data, and at 36 months, 5 years. This data can and should be used to feed into bigger population data sets where they exist, and it's something that the GFAOP is working on and constantly encouraging units to share their data. So that is really all I have to say to you. That is all our project network. These are all the people that I work with, heads of units, the research staff, the specialists in France, Dr. Jacqueline Clavel, Eva Steliarova, both are working with us, and in the GFAOP, the different people who have helped with this project, and of course, Sanofi, the My Child Matters program. Thank you very much for your attention. I don't know when the questions are. I'm sure Venkat will tell us. Thank you.
Thank you, Brenda, for this amazing talk and the great work you have done. Maybe we'll take one or two questions before we go to Karla, and then we can take further questions later. Natasha from South Africa has asked, was the staging based on the Tier 1, the Toronto staging in your this thing, or was it Tier 2 staging?
No, it was T1. We were able to, 89% was the T1.
89% was T1.
Yeah.
And has this generated any interest in the government's, any policy change, your data, your report, has it influenced the health ministries in these countries to act upon based on what you published?
I work quite closely at one stage with Dhaka, which is the country, one of the countries that has been chosen by the OMS to promote cancer plan. And the Ministry for Health, I have been in contact with Dr. Malik Ann, who is responsible for non-contagious diseases. And he is very, very interested and took part in a meeting where we were showing our data for Dhaka. He was very surprised when I showed him that not all children were getting there, and that there were children with a central nervous system tumors that were found in neurosurgery departments, but they never actually got to the pediatric oncology unit. And he was rather surprised about that, and also leukemia cases that never got to the unit. But one of the reasons is probably because the unit has limited number of places, so they will have they will prefer to take in children for whom they have protocols and they have a treatment. So he was very interested in that, and they are working very hard to develop a cancer registry. And one of his ideas when he heard what I was saying, that maybe they should develop a childhood cancer registry first in the region of Dhaka. So, you know, obviously we would encourage that given what we're doing. Also the quality of data that we discussed, you know, not taking all of the data, trying to limit the data. So we have encouraged them to join the African Hub. As you see, it's one of the countries that hasn't joined the African Hub so far, and they were very interested in that. So yes, there is the interest, taking the next step.
Hello, I think we lost. Can you hear me?
Yes, thank you.
Yeah. In the interest of time, I'd like to invite now Dr. Karla Rodrigues from Brazil. She's also done incredible work in establishing a network of hospital-based registries in Brazil called the AMARTE Alliance. So welcome, Dr. Karla, to share your work, and waiting to hear from you.
Thank you, Venkat. Thank you, everybody, for being here and giving us the opportunity to share our experience in Brazil with the AMARTE Alliance registry implementation. Can you see my share, my screen?
Yeah, we can see it, but it's not full screen.
But not in the presentation mode yet.
Yeah,
Okay.
yeah. Now it's visible.
Now it's okay.
Yeah, it's perfect.
Great. So I'd like to thank Venkat and the St. Jude Global Program for the opportunity to share with you the experience in Brazil, building our registry. So Brazil is a continental country with great disparities in the socioeconomic context. According to the latest census, we have 200 million inhabitants, more than 200 million inhabitants, and more than 100 million inhabitants are under the age of 20 years. And we have an expectation of about 8,000 new cases of childhood cancers per year. The distribution according to the cancer-related mortality deaths in Brazil is around 42.6 cases in children and adolescents. There's a study conducted in Brazil that evaluated the mortality among children and adolescents from 1996 to 2017, and they evaluated the mortality across 133 institutions or regions in Brazil, and they could see that the mortality, the trend of cancer mortality in childhood and adolescents has a tendency to decrease, but they found that the higher mortality rates were observed in the northern region among the boys and among the group under the age of 4 years old. And they observed that this happens mainly in the regions with the lack of ICU beds in the public healthcare system. So the cancer registries, as we know, are vital tools to researchers and policymakers, and they help monitor disease trends and provide key statistics that are essential to plan and evaluate cancer control strategies. However, many of these registries, as we know, either don't collect the staging data according to the TNM, that is the adult cancer most common classification, but that is not suitable for the pediatric cancer, the most pediatric cancer types. And usually the childhood cancer staging systems are disease specific, and they change according to the protocol of treatment that it's used. So this limits the utility of registries for the pediatric population. And also in the low and middle income countries, we usually struggle with limited access to advanced diagnostic imaging, and this complicates the data collection according to the accuracy for the staging. Aware of these disparities and eager to change the national pediatric oncology landscape, a group of 13 pediatric oncologists got together from different regions in Brazil in 2019 and founded the AMARTE Alliance with the support of St. Jude Global Program. AMARTE in Portuguese means to love you, and it's in the context of the alliance, it is an acronym that stands for greater support, increasing research, and specialized training. From the beginning, the Alliance prioritized the creation of a pediatric cancer registry. However, choosing the most appropriate tools for our reality, considering mainly the ethical and the legal aspects, this took a long time, more than a year discussing and having meetings to find our own way. Finally, in 2021, with the support of St. Jude, the SJ Cares and Registry team, and with the support of our IT and research team here in Barretos Cancer Hospital, we decided to work with the registry tool developed by the SJ Cares team from St. Jude, and within the REDCap platform that is based on the serve in Barretos Hospital Cancer. And together we decided to start the registry implementation to collect the data from January 1st of 2022. From that point on, a joint effort was made by the AMARTE Alliance to translate the training materials for the use of the registry tool into Brazilian Portuguese, including recording the training voice-overs by Alliance members from different regions of the country. And this made the training in our country even more special because we have different accents in the different regions in the country, and it was very it converted in a very powerful sense of inclusion and belonging to the Alliance. Since then, new pediatric oncology centers have joined the Alliance, and in 2024, the Subcommittee on Registry and Epidemiological Data was created, and at the same year, we held our first AMARTE Registry in-person meeting with the support of St. Jude as well. This is the governance structure of the AMARTE Alliance, and the registry is under the umbrella of the Executive Committee and the Epidemiological Data Subcommittee of the Alliance. The pillars of the AMARTE Alliance are described here, and they are the standardization of the diagnosis and treatment, studies on epidemiological and survival, and the scientific development and innovation. These are the institutions in Brazil that now joined the Alliance. We are 37 centers nowadays, with 5 more in process to join the Alliance. And together, these institutions will have more than 6,000 new childhood cancer cases per year. The implementation process of the AMARTE Alliance's registry in each center involves some key steps. First, the Pediatric Oncology Center expressed its interest in joining the Alliance. After signing the cooperation agreement, the institution appoints a healthcare professional, usually a nurse, that will be the data manager, and a pediatric oncologist that is also designated to act as the medical monitor for the registry. These 2 professionals must work together to ensure the quality of data abstracted from the patient's medical records. The next step is training this team in the use of REDCap platform and the registry tool. This training includes basic principles of pediatric oncology, cancer nomenclature, data abstraction, and the process of data entry itself. A crucial focus during this phase is data security. Each professional receives an individual and not transferable login and password for database access. And each institution can only access its own data, and they don't have access to the other Alliance member institutions. Once appointed, these professionals must become members of the AMARTE Alliance Registry Subcommittee, and they are required to participate in monthly virtual meetings, and that is held on the first Tuesday of each month at 4 p.m. These meetings include case discussions to clarify doubts regarding data entry, ongoing training, and important communications. Additionally, a WhatsApp group is used to facilitate communication. The next step involves the training on how to apply the informed consent, and this is compliance with the Brazilian General Data Protection Law. After all these steps are completed, they start collecting the data. The registry has specific deadlines that must be followed. At the patient admission, the identification and demographic information must be collected. Within 3 months of admission, diagnostic and staging data must be entered. 3 months after the start of treatment, the information of treatment should be collected. 6 months after the end of treatment, the first follow-up must be completed. And additionally, the follow-up form must be also filled out at any time in the event of disease progression or patient death. This is the layout of the registry within the AMARTE Alliance REDCap platform. And it's important to highlight that as part of our agreement with the St. Jude SJ Care team, we cannot modify any of the variables that they created. However, we are allowed to add as many variables as we think it's necessary. Here you can see the mandatory variables of the SJ Care's registry tool. And here, circled, you can see some new variables that we added in the AMARTE Alliance to monitor the initiatives currently being developed by the Alliance, such as tracking the lysis syndrome, the tumor lysis syndrome, and the standardization of the pathological diagnosis of central nervous system tumors. Here we have some photos of the AMARTE Alliance Registry Coordination Team and the research support team from the Barretos Children's Oncology Hospital, who provide all the logistical and training support to the subcommittee members, and the registry SJ Care's team from St. Jude, Dr. Nikhil and Montserrat. And I'd like to take this opportunity to thank them all for their support throughout the entire process of implementing our AMARTE registry. Among these photos, we captured key moments from the journey that I'm talking to you, from the creation of the AMARTE Alliance in 2019 until nowadays. And many of these moments took place virtually up until our first in-person registry meeting that was held in Barretos last year. And this gathering brought together not only the registry representatives from each AMARTE Alliance institution and the St. Jude team, but also the fundraising teams from those institutions and from outset at St. Jude to discuss a long-term sustainability strategy for the AMARTE Alliance Registry. At this meeting, we had the participation of over than 150 people during 3 intense days of work and training. At the beginning of the registry implementation, our virtual meetings were held every 2 weeks, and it was only last year that we transitioned to monthly meetings. So far, we have held over than 70 meetings with an average of 14 participants per session. Nearly 100 professionals have already been trained in the use of Registry and REDCap platform. We started with an average of 100 cases registered per month, and we have now surpassed 200 cases per month. Among the main challenges we face in ensuring the sustainability of the registry, the lack of professionals dedicated exclusively to registry activities is certainly the most significant. Typically, the registrars are nurses whose work hours are split between registry duties and clinical care or other administrative tasks at the hospital. Often, once they are well trained, their supervisors reassign them to other responsibilities, or they are hired by other institutions offering higher salaries. Among the strategies we are developing to address these barriers are discussing a fundraising plan to support dedicated personnel and infrastructure, developing partnerships with foundations and government entities to secure long-term support, and conducting local visits to the sites to perform situational assessments and better understanding the center's specific needs and challenges. This is one of the moments of the visits, and the local visits are not only an opportunity to deeply understand the reality on the registers at each center, but also to support them in developing strategies to overcome their specific barriers. Additionally, these visits allow us to place a stronger focus on the data quality. Before the visit, we perform a data consistency checking for the institution's data, and we present them the findings so they can review the data and make the necessary corrections, ensuring the reliability and accuracy of the data they collected. So now I'm going to present you some preliminary data of our data collection. So far, we have had almost 7,000 new cases registered. However, some data still needs to be completed, causing the total sum of the variables constantly changing. Among these cases already classified, most are analytical cases. Most are male, and the median age is about 95 months of age. The best diagnostic method used was microscopic verification. Regarding the patient's trajectory from the perception of the first cancer symptom to the beginning of treatment, it's possible to observe that there are very extreme values that need to be checked. However, it's also possible to identify a huge gap in the time between the first medical assessment and the establishment of the diagnosis. The hematological neoplasms and the central nervous system's tumor are the most frequent neoplasms. And regarding the status of the patients who have already reached this data collection phase, the majority are alive. Among the patients who are dead, the main cause of death was disease progression. However, infection was an important cause of death. And additionally, more than 10% of the deaths occurred within the first 30 days of treatment. In the future, will be interesting to observe the impact of some initiatives being developed by the Alliance, such as the training of nurses and intensivists in pediatric oncology for the recognition of the specific needs of pediatric oncology patients, the development of the EVAT and Golden Hour projects for the early recognition of clinical deterioration and neutropenia, fever neutropenia, and the CISPR project that is working to reduce the time to diagnosis. Regarding the use of Toronto staging system, it's possible to observe that many solid tumors present with advanced disease, and we hope with the CISPR study group on the pilgrimage of the patients to understand the trajectory of these patients and develop action plans to reduce the time to diagnosis and perhaps reduce the stage of the disease at diagnosis. We know that we still have many challenges to face, but certainly they are not greater than those faced by our patients and their families. And finally, but not least, I want to thank all the members of our registry who are bravely dedicating themselves to changing the history of pediatric oncology in our country. Thank you.
Thank you, Dr. Karla. Again, amazing work. So many years to collect this data, but so much, it's gold mine of information for people across the world. There are a couple of questions. We have a question from Dr. Alice. She wants to know whether the AMARTE Alliance is under the direct supervision of Brazilian Ministry of Health, and which institution is responsible for all logistic support, the hardware, network, database, local storage of data, backup, and security.
Actually, we last year we started some discussions with the Ministry of Health, but officially they do not support our alliance yet. Of course, there are some projects like this that I talked about, the CISPR, about the pilgrimage, that we could have some funding to perform the study. That is one of the initiatives to work together with the Ministry of Health. But not all the activities developed by the Alliance are supported by them. But we hope so we could in the future. Thank you for your question.
And the next question is, how do you reduce duplication of data when multiple centers are registering?
Yes, one of the strategies is in the meetings that we have each month, discussing about the possibility of duplication of data when the patients are transferred from one institution to another, to check on this. So the main strategy is about having these meetings, these institutions together discussing about these doubts.
I think also.
Yes, Brenda, sorry.
Just on that note, I think we have the same power in having multiple centers, and I think selecting the variables that need to be controlled for, like the name of the child, the sex, the age, the date of arrival. We actually put in 2 areas. Are the children coming from another center within the country, or are they coming from another country? So that we're not counting the same child twice in one unit in one country and one unit. And we have identified very often children coming, but we were very precise in the variables that we chose. So that was a selection that we worked on. So that needs to be, if you're going to have multiple centers, you really do have to have those sorts of checks put in, I think, as well.
Yes, I agree. I totally agree. And another very important aspect is a variable regarding the class of case, because we're gonna work with statistics for the analytical case, that case that were a new case for the institution with or without diagnosis, or that those who have diagnosed, but they didn't have received the treatment, the chemotherapy treatment yet. So this is another strategy for that we don't have the doubled register.
Erin, Miho, they're my colleagues from the network. Any comments?
Now, from my side, this was wonderful work. Thank you so much to Brenda and Karla for sharing your work. I think many of us here have left feeling very inspired about what you've been able to accomplish.
Absolutely, yes, it's quite inspiring, and I think we are overshot by almost 10 minutes, but it was worth it. Thank you once again for all of you for joining. Please become a member of the CEOP Epidemiology Network. You can go to the CEOP website, and once you register, you have to be a member. Then just go and select which working group you want to be a part of. So please click on CEOP Epidemiology, and we have many more webinars lined up, and we'll be in CEOP Amsterdam as well. So have a good day, and thank you.
Thank you. Bye-bye.
Bye.
Thank
Thank you.
you.
Thank you, Karla. Thank you. Fantastic.